Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. So today our lecture is about back pain. Back pain is very high yield, very commonly tested. So regardless of which exam are you going for, MCQ1 or NACOSKI, this is something that you need to know before you go to the exam. So the exam priority rule out the red flags. Remember, when you're dealing with a low back pain, especially if you're dealing with a Nakoski, you have to like verbalize it, say it very loudly that I am trying to rule out the red flags. And even if you're doing the MCQ one or preparing for MCQ one, when you're reading the scenario, look for the red flags. Okay, it really helps you to come up with the right uh, answer. Now, common reality, most cases are mechanical. Remember that usually by IMGs, when they are mistaken they're taking the case too serious and go after the prolonged rest. So remember that most of them are mechanical. So the most you can like if you see anyone that who has back pain, the most that you can give him rest is like 1 to 2 days. Then they have to be active because one of the part that or the aspect that helps them to get rid of the pain is the activity. Sorry. All right. So the key skill, avoid low value imaging. So based on the case, go ahead and do the imaging if required. If not, do not over investigate. So these things matters when you do the NAC, OSCE, or MCQ1. By the end of this lecture, you should be able to, step one, recognize the risk. This is the most important part of the back pain that we do. And any case that you're doing, you have to like go after the red flag. That is priority number one, especially if you're dealing with a back pain. So recognize the warning sign and urgent issues. Step two, identify the pattern, distinguish between the mechanical, radicular, and severe pathology. And third, assess with the NAC OSCE perform focus history and neurological examination, which we will do it in the in-person classes. Step four, apply imaging selectively, refrain from routine imaging and simple acute low back pain. And the last, treatment and planning. Initiate first line therapy and offer safety net advice, which is going to be part of the discussion today. So rule out emergency. The emergency condition that we need to rule out when we are dealing with a back pain is Cauda equina is on the top of your list. They love to test you on this one. Whether you're doing NACOSCI, whether you're doing the MCQ1, especially in MCQ1, they love to test the Cauda equina syndrome. And also, it could be part of the post encounter in NACOSCI. Infection, very important. Cancer, very important. Fracture, trauma, vascular, especially abdominal aortic aneurysm, which is part of the referred back pain. It is not back pain, but it is a referred back pain. So when you're ruling out, you need to even do an abdominal examination or at least verbalize it for the examiner that I am looking for abdominal aortic aneurysm and pancreatitis and renal colic, because those are going to be what? The referred pain. But in case of emergency, abdominal aortic aneurysm would be on the top of your list in terms of referring pain. Classifying pattern, mechanical, which is non-specific. We will talk about every single one of them. Radiculopathy, sciatica, serious pathology pattern, treat and safety net, stay active. If you guys remember, at the beginning, I mentioned that usually I notice that a lot of IMGs, they prefer to give the patient more rest. And that's when you lose mark, because for the most part, especially when you're dealing with a mechanical, staying active actually helps with the treatment. But if you provide them with a long rest, it makes things even worse. Short-term analgesia, exercise, physio, return precautions. High yield takeaway. Most acute lower back pain without red flags, no imaging. So if you have anyone that who has lower back pain, but you cannot find any red flag. When I say red flag, for example, you cannot find any neurological symptoms, you cannot find any systemic symptoms, you cannot find any urinary symptoms or bowel movement symptoms or sensation, things like that, then you don't have to do imaging. So imaging is not necessary for all back pain. It has to be ordered on a specific condition, which we will discuss it. So plus stay active, short-term analgesia, plus follow-up. Safety net, return immediately for a new weakness, subtle anesthesia, fever, and bowel bladder changes. So when you're discharging somebody, who has back pain, things that's very important to educate the patient to come back immediately, or those are the warning sign that he has to come back to the emergency room right away, or the closest emergency room to his place, is new weakness, subtle anesthesia, fever, bowel and bladder changes. Red flags and emergency, I think we did mention urinary retention, overflow. When we say urinary symptoms, it's either incontinence or overflow or retention. Fecal incontinence, again, same thing, subtle anesthesia, which is part of the cauda equina. The patient would have back pain, but not only back pain. With back pain, the patient would have urinary symptoms like retention, overflow, fecal incontinence. One thing that I forgot could be erectile dysfunction, subtle anesthesia, bilateral sciatica or progressive weakness, action, emergency, department now, urgent MRI, and a spine consultation. So the patient needs surgery right away. So the next step for us, depending on the options that you have, we cannot deal with it. So we have to refer it to the emergency department right away. So for the emergency department, what do they do? They have to do MRI. For this patient, they have to do the MRI and the surgery. OSCE script, say out loud. So my first priority is to rule out cauda equina, infection, cancer, and fracture. These are the red flag. So these are the red flag that you need to rule out, or the condition that it has to be on top of your head. Once you get into the station, if you're dealing with a back pain, cauda equina, infection, cancer, and fracture, you have to rule them out. If this is one of the condition like cauda equina, then you know how to approach the patient. But this is our priority when we are dealing with a back pain. We have to rule out cauda equina, infection, cancer, and fracture. Infection, malignancy, and fracture. So how do we know if it is infection? How do we know if it is malignancy? How do we know it is fracture? Obviously, the patient with the infection would have systemic symptoms, right? The patient would have fever. The patient would have recent infection. The patient will be IV drug user and immunosuppression, or the patient will have some sort of immunity disorder and the patient is receiving some sort of, for example, immunosuppressant medication. History of cancer, the patient would usually have history. For example, you have a patient, the patient has back pain, but the patient has history of prostate cancer. Now it shows that the patient prostate has metastasis to the spinal, to the spine, or the back pain is secondary to the cancer. So the patient usually give you a history of cancer and the sign and symptom of cancer, which is constitutional sign and symptom. For example, weight loss, fever, sweating, lumps and bumps, bleeding, and so on and so forth. And breast pain. For the cancer, there is no position or posture that relieves the pain. They will have pain all the time, and it's constant in every posture and position. Trauma, osteoporosis, chronic steroid. So for this one, it usually referred to fractures. So fracture happens when there is a trauma, right? Accident, car accident, fall, and anything that has to do with a trauma. Secondly, if the patient has history of osteoporosis, or if the patient is taking some sort of steroid for a prolonged time. For example, the patient has rheumatoid arthritis and the patient has been taking a steroid for years now. So steroid causes the weakness or fragility of the bone, and with a very mild trauma, the patient will have fracture. So these are the things that are clue to the fracture: trauma, steroid, chronic steroid use, and osteoporosis or history of osteoporosis. So what are the action targeted labs based on those specific things? Plus imaging, urgent referral when indicated. Return percussion to emphasize knee weakness. We did talk about this. Knee weakness or foot drop, bowel, bladder change, subtle anesthesia, fever, or feeling unwell. Mechanical or non-specific low back pain. This varies with activity and posture, but usually the patient will have pain, but the pain will improve with rest. Improves with rest or position change. The thing about mechanical back pain is the patient has back pain, but no other symptoms, like no systemic symptoms, no fever, no tachycardia, nothing, just pain. And no neurological finding, like no weakness, no sensory deficit, nothing. Only pain in the lower back. Most improve within weeks, and most of them will improve within weeks, and exercise and being active and so on and so forth. Now, radicular pain or sciatica. The pain is leg dominant pain, radiating below the knee. So it means the patient has back pain and leg pain. But the leg pain is more dominant than back pain. So it means the patient has back pain, which is shooting down the leg and it goes below the knee. And the patient complains more from the leg pain rather than back pain. Or at the same time, they're complaining from both. But the leg pain is usually more dominant than back pain. So dermatom, numbness, tingling, a straight leg test is very specific or a special test for sciatica, which we will do it in a physical when we are doing the physical examination. Possible weakness, reflex changes, imaging only if red flags are persistent, progressive, or positive. So serious pathological pattern, the pain will be constant. Remember, these are the things, if you notice, it's all red. So if you see the pain that's constant, there is no change in the pain while the patient is changing position or posture. There is no change. If the patient is walking, the pain is there. If the patient is sitting, the pain is there. If the patient is lying down, the pain is there. If the patient is flexing, the pain is there. If the patient is extending the back, the pain is there. This is serious. It could be malignant, okay? Progressive, not only constant, it is progressive. Today it is 5 out of 10. Tomorrow it is 6 out of 10. The day after tomorrow, it's going to be 7 out of 10. So it's progressing, getting worse and worse. Not only it is constant and different position or posture, but it is getting worse and worse. And it is not only during the day, as I mentioned before, it is constant. So the patient will have the pain throughout the day and throughout the night. Fever, weight loss, major neurodeficit. So escalated. It means you have to do further investigation. And most likely, if you have pain that's constant, not changing, not relieving, not getting better with any posture, and it continues to be persistent during the day and throughout the night, then it's most likely malignant or metastatic. Now, this is the best. I love this slide. So, a few things that I'm going to explain here, and I need you guys to pay attention because it will help you a lot with back pain and scenarios in the back pain. So, I give you two scenarios, one uh, about the Nakoski and one about the MCQ one. So in the Nakoski, if they give you, let's say, a spinal stenosis, a few things they will mention. For example, they will usually give you a scenario about somebody who is elderly, like old patient. And then the patient has pain. The pain is in the lower back and it radiates to the both side, to the both legs, to the both lower limbs. Okay? Elderly, back pain, radiating to the both side. Now, this patient, the pain improves when the patient is pushing something or flexing forward. If you notice in this picture, if you notice here, if you notice right here, you can see the patient is flexed forward, pushing. They usually give you a scenario about someone who is old, back pain relating to the both side, and the patient's pain improves while the patient is leaning forward. And it gets worse when the patient is leaning backward. Now, take a history. So you already know I have an elderly, the pain is at the lower back, it radiates to the low, and the patient pain gets better when the patient is flexing forward, and when the patient is extending backward, the pain gets worse. So it is spinal stenosis until proven otherwise. For me, this is spinal stenosis. So you will arrange it based on your structure or OCD, PQRST, whatever you're doing. Yeah? Like in back pain, we do that. Now, in the second scenario, again, they will give you a scenario about an elderly with a back pain, and then the patient, they will give you this same elevating and aggravating factor, but indirectly. For example, elderly with a back pain, and he complains that when I go for shopping, when I push the shopping cart, I feel good. I like the pain goes down, but when I'm pulling back the cart or shopping cart, the pain increases. Or they may give you another scenario that there is an elderly. The patient has back pain. It reduces to the lower, both side of the lower limbs. And the patient says the pain increases when I go downstairs. When you go downstairs, I don't know if you guys have noticed, when you go downstairs, you usually slightly extend your back. Why? Because you don't want to fall down, right? So when you extend your back, that's when the pain increases. Or when you're going downhill, again, you're trying to hold your balance by extending your back. That's when the back pain increases. Or when you're going up stairs, obviously you're going to flex a little bit so that you can hold your balance. That's when the pain goes down. Or when you're going uphill, again, you're flexing your body so that you can control your balance. That's when the back pain decreases. So this is how they put it in the scenario. If you see that someone who pushes things and the pain gets better and pulls things and the pain worsens, it is a spinal stenosis. For sciatica, the pain, when does it increase or decrease? So bending forward is the opposite of what? Spinal stenosis. The patient, when bends forward, it increases, as opposed to spinal stenosis. When the patient was bending forward, the pain was relieved, right? It was getting better. But here it is the opposite. When the patient is bending forward, the pain increases. When the patient extends the back, this is when the pain relieves. That's why when you do the straight leg test, because you're bending the patient, it will be positive, which is a special test for sciatica. For the cauda equina, severe lower back and leg pain. Not only that, the patient will have subtle anesthesia, or the patient may tell you that I cannot feel between my uh, anal area up to the scrotum, or in most cases, they cannot even feel the scrotum, the genital area as well. That's when they can't feel it. That's why they lose the bowel and they have fecal incontinence. Walking causes the pain to decrease a little bit. So it's not going to go away, but it will have some relief. And for cauda equina, remember that the urgent surgery needed to relieve nerve compression and prevent permanent damage. And if somebody is sitting in sciatica, if he is sitting somewhere like in a low surface, again, when you're flexing your back, again, the pain will increase. For the pain, OCD PQRST, UV, AAA. O stands for onset, course, sorry, I have to add E, course, duration. Remember for duration, if the back pain is less than 6 weeks, it is acute. If it is 6 to 12 weeks, it is subacute. If it is more than 12, then it's chronic. So position, radiation, severity, time, your daily activity has been affected or not, deja vu, have you had it before or not, associated signs and symptoms, aggravating factor, elevating factor, mechanic worse with the movement, posture, better with rest. Night rest, usually it is either infection or malignancy. Neuro numbness, weakness, gait, change, foot drop, usually they are due to cauda equina. Bladder again, systemic symptoms, risk. Remember for the IV drug and immunosuppression, usually if they want to test you, they usually test you on somebody that who has back pain, but severe back pain, severe back pain. So to give you a scenario about someone that who is living on the street, homeless, and now the patient has severe back pain. And there is a local tenderness when you're checking, when you're doing the physical examination, there is a local tenderness. So what is the diagnosis? Now, in this case, you know, this is infection. It could be due to low immunity of the patient. And the main reason, which we usually notice that when they give you this scenario, they usually give you a scenario IV drug user. Okay. We're going to discuss in detail. Minimum exam sets. So vitals, always remember we have to check it. Why? Because we need to know if the patient is stable, unstable, if there is a fever or not. These are part of the physical examination. So usually when you go for the physical examination, they will provide you with the vital signs. If it is not provided, you have to say that I will start my physical examination with checking for the vital signs. And then look at the examiner, and the examiner will tell you, ignore it, it's all normal. Or he will tell you that blood pressure is this, pulse is this, the temperature is this, the respiration is this. But in most cases, it will be provided for you. Let's say if it happens that they forgot, please do not forget it. You never start any physical examination without checking the vital sign. This is always come first. Always it comes first. But if you have it, just mention that since I have the vital sign, I will skip it. Still, you have to mention it, okay? Since my patient, I have the patient's vital signs in the file, I'm going to skip it. You have to verbalize it for the examiner so that he knows that you have to do the vital sign and he will give you a mark for it. So vital signs, gait plus heel toe walk. We will do this when we do the physical examination. Lumbar range of motion, palpate middle line tenderness. And why do we do that? For that specific condition. Neuro L2 S1 strength sensation reflex straight leg test. These are the specific tests that we do, and I'm gonna give you guys more specific or special tests for the lower back. If cauda equina, cranial sensation, anal tone, we did already talk about that. Documentation that scores well, neuro exam normal, or a specific deficit, sensation dermatomes, strength key muscle groups, reflex. These are part of the physical examination. We will do it. Reflex, patella, Achilles, and a straight leg test result. And if there is any red flag, we noted. If not, we will mention. So, rule of exam, uncomplicated acute lower back pain less than 6 weeks. We mentioned if it is less than 6, it is acute. 6 to 12, subacute. More than 12, chronic. So the patient is having an acute back pain and there's no red flag. So what should I do? No imaging. And then when do we do the image? If there is red flag, what do I mean by red flag? If the patient has history of cancer, if the patient has sign and symptom of cancer or malignancy, I mean by that constitutional sign and symptom. If the patient has infection, if the patient has fracture, or the patient has history of osteoporosis or chronic use of steroid, or the patient has sign and symptom of cauda equina. Severe progressive neurological deficit, then I can do the imaging. Persistent radiculopathy symptoms will result change management, planning a specific intervention. Now, if I have to do the imaging, what is number one, what is number two, and what is number three? For the back pain, suspected cauda equina infection, malignancy, persistent radiculopathy, for these conditions, which are the red flags, for these ones, I have to do MRI. Okay, MRI. And CT, if MRI is not available, X-ray, trauma, fracture, risk patterns. So usually we do, if they're asking you about the first imaging, usually in general rule, we usually start with X-ray. But depending on the condition, for example, if the patient has cauda equina, we can't waste our time doing the X-ray. Or if the patient has infection or malignancy, the X-ray might provide you with information, but it's not going to be very exclusive. So it's waste of time, waste and exposing the patient to more radiation. So it's better to go with the MRI. First line plan, what examiner wants to hear. This is very important. Reassurance plus educate. For what? For mechanical. For mechanical back pain, you need to provide reassurance and educate natural cause, avoid bed rest. In a worst case scenario, like if you have to provide rest for the patient, do not go beyond 2 days. So avoid bed rest. Again, the rest for these patients, it will even worsen the symptoms or worsen the case. Stay active and return to normal activity as tolerated. Short-term analgesia, non-steroid anti-inflammatory drug. If safe, consider acetaminophen depending on a patient factors. Exercise, physio, mobility, graded strengthening, heat as supportive therapy. Safety net, return for a neurodeficit, fever, bowel, the rest we know, right? Avoid routine imaging for them. For the non-specific and mechanical, we don't do imaging, prolonged bed rest, and long-term opioids. These are the things that we need to avoid. So you might get this question as a past encounter, like, what is your most likely diagnosis? You will say it is mechanical or a non-specific back pain. Okay, so what are the things that you need to avoid in this patient before you discharge the patient? So I would avoid educating the patient, or I would avoid advising the patient to rest for a longer period of time, for example, for 1 week or 2 weeks. I would encourage the patient that this is a condition that is self-limited and you need to be active if you want to get better soon. And also long-term opioids, I would avoid prescribing opioids for a long period of time. So stuff like this has to be on top of your head, okay? What it looks like, leg dominant related to the pain. So we're talking about sciatica. So I think we did talk about this. I'm not gonna waste your time. Skin reflex, we already discussed this as well. So imaging principle, MRI is typically preferred when imaging is needed and result will change management. So again, MRI for sciatica, the choice imaging would be MRI. Now, chronic back pain, if it is more than 12 weeks, psychosocial care. So for somebody who has back pain, but the back pain is for more than 12 weeks, or it is a chronic back pain. Treat chronic lower back pain as a function limiting condition influenced by physical, psychological, and social factor. Exercise based rehab, graded activity, core conditioning, and pacing. Functional goal, walking tolerance, return to work plan, and active daily living. Address yellow flags, fear avoidance, mood, sleep, work stress, and rational meds, short-term symptoms relief, avoid long-term opioids. For them, it's more like exercise, physiotherapy, conditioning, and more dealing with the stress, anxiety, and sleep, mood, and stuff like that. Use these to structure your encounter. My first priority is to rule out, as I mentioned before, that you have to, for high scoring in NACOSKI, these are the things that you need to plan. And not only plan, you need to verbalize it and let the examiner know that you are actually, you actually know this and you want to do this. My first priority is to rule out cauda iguana, infection, cancer, and fracture. I will ask specifically about when I'm doing this. So I'm going to specifically ask about the bowel bladder changes and exam the neuro status because this might be part of your post-encounter question. There are no red flags, so I will not order imaging today. So sometimes when we do the station, we think that now since I have ruled out all the red flags, now the examiner knows that I know that I don't have to provide imaging. But remember, they expect you to verbalize it. So they're not mind reader. We have to say, since my patient, so I verbalize it and I say that very loudly, since my patient has back pain, the first priority for me is to rule out the red flags, to rule out the viral conditions or to rule out the dangerous condition like cauda iguana infection, cancer, and fracture. So since the patient does not have all these red flags, now I would not suggest or order any imaging today. I will focus on function and recovery. Now, the examiner knows that you know how to deal with a patient with a back pain. Now, the plan is to stay active, short-term analgesia, if safe, exercise, and clear return precaution. Tips. When you decide no imaging, explicitly document no red flag, normal neurological exam. So if you decide not to order it, you have to have a reason for it, and you have to write a note that for these reasons, I do not see fit the investigation to be escalated, or I do not prefer to order an imaging. Why? Because there's no red flag, there's no neurological finding. And it could be part of the documentation and prescription. So now let's talk about the differential diagnosis, which is very important. It might be part of your question or part of the station that you need to do a back pain differential diagnosis. So mechanical back pain, usually the key clues, it is also helping you guys a lot with the cases in MCQ1. So the clues is posture, movement related, improves with rest, no neurological exam or finding. So reassure the patient, stay active, short-term analgesia, no imaging if no red flag. We usually don't do anything, just analgesia, reassure, educate the patient, and also encourage the patient to stay active. Disc herniation radiculopathy, leg dominant usually, radiating pain, dermatomal paresthesia, straight leg test will be positive, straight leg raise test will be positive, weakness and reflex change will be positive. So for this patient, conservative care first, MRI if persistent and progressive. So it means for all sciatica, we don't do MRI unless it is persistent and it's progressive. So even for the sciatica, the patient will get better with the physiotherapy and exercise. But if it happened that your patient with sciatica is persistent, the pain is persistent and progressive, getting worse, then MRI. Okay. Now, for the spinal stenosis, the patient usually will be older or elderly, neurogenic claudication, worse walking, standing, better with sitting and flexion. So, function-based rehab, image if needed for the planning and referral. Cauda eguana, obviously emergency, you cannot forget about this. Urinary retention, sudden anesthesia, bilateral symptoms, and progressive weakness. And another thing, not urinary retention always, it could be urinary incontinence also, it could be fecal incontinence, and also it could be erectile dysfunction. So emergency, urgent MRI, and spinal consultation. Infection, obviously the patient will have fever. The patient will somehow it will be mentioned in the scenario the patient is homeless or living on the street. So that gives an idea the patient might be IV drug user. The patient would have some sort of immunocompromised condition like HIV and AIDS and so on and so forth, severe constant pain, middle line tenderness. Midline tenderness is very important when we do the physical examination. You would know that for palpation, how do you do the palpation to find the midline tenderness, plus minus neurogenic or neuro deficit. So labs for this patient, usually since it's infection, it will be infection and inflammation at the same time. So ESR and CRP will be high. Urgent MRI, admit, IV antibiotic as indicated. Malignancy, cancer history, as I mentioned before, the patient might have history of prostate cancer. And the patient would have weight loss, night sweat, wrist pain, and progressive course. Urgent imaging, again, workup and referral pathway. Compression fracture, the patient usually give you a history of trauma or a minimal trauma in a patient with the osteoporosis or in a patient with a steroid, like a trauma or a very minor or minimal trauma in a patient that who has history of osteoporosis or who is for a long time on a steroid. Focal midline tenderness, again positive, appropriate imaging, analgesic, osteoporosis management. Now, these are the differential diagnose that has the picture and the same thing. So I'm not going to bother you with this. You should be able to have it in the notes. So for the epidural, spinal epidural biopsy, out of all of them, remember, if they want to test you on this one, they usually give you a scenario of a homeless that who have fever, severe back pain, and the patient is living on the street and midline tenderness, ESR and CRP is high. What is your most likely diagnosis? It could be a spinal epidural biopsy, osteomyelitis. Okay, do not forget, if they want to test you on this one, they will definitely mention the IV drug user or immunocompromised patient. But out of these two, I have seen IV drug user in so many question banks. So it means it is commonly tested. Remember, spinal epidural biopsy, osteomyelitis, and IV drug user. Very strong relation between these two. And ESR CRP will be high. So very short, concise algorithm. Patient with back pain, screen red flags, infection, all those. And then if it is yes, urgent imaging plus consultation. If it is no, classify pattern. It could be mechanical or radiculopathy. Treat safety net, no routine imaging. And thank you very much. Now, if you guys have any question, I'm at your